Good morning, everyone. I'm with the Macular Degeneration Association, and we are happy to welcome you to another year of programs that we are offering. We are able to do these programs because of our wonderful sponsors, such as Regeneron, Apellis, Sun Pharma, AbbVie, MacuHealth, Novita Vision, as well as the appreciation and help from our medical director, or medical board, from the Macular Degeneration Association. We are now going to turn our attention to the speaking portion of today's program, and the doctor that will be starting us off is Dr. Gerson. He's the medical director for the Macular Degeneration Association. He graduated from Indiana University School of Optometry, where he went to do his residency, to continue his residency, concentrating in low vision and ocular disease. Currently, Dr. Gerson is in private practice that is in collaboration with both ODs and MDs. He is a primary care physician and has an emphasis on retinal care in his practice. He enjoys having fourth-year optometry interns with him and the challenges that they present. He participates in clinical trials and utilizes many different diagnostic modalities. Dr. Gerson is a frequent lecturer and writes regularly for optometric publications. Dr. Gerson will first be speaking to us about, can diabetes affect your eye? Dr. Gerson, you have our attention.
So first of all, thank you to everyone for coming. This is a great showing. I appreciate you being here. As Dusty said, I'm an optometrist. I practice in Kansas City, so I'm here with Dusty and Donna to do this morning, and then we're going to Phoenix this afternoon. And we're going to start off for a few minutes talking about, can diabetes affect your eyes? And the really short, easy answer is yes. Okay. But we figured we should probably talk a little bit more about it than just answer the one question. It's first really important to note that in a room this size, there's probably 15 to 20 people that have diabetes. And so diabetes is quite common, even more common as we get older. So in this room, it's probably between 1 in 2 and 1 in 3 of you actually have diabetes, which is a lot more than it would have been 20 or 30 years ago. It seems as though more and more people are developing diabetes. So it's one of the most common conditions that we deal with in the United States. Dusty, I'm not sure if we're working here. Oh, there we go. So what's the big deal? Diabetes is a leading cause of death. It is the leading cause of blindness in people under age 74. It's a leading cause of kidney failure, amputations, and it's really expensive. So diabetes can lead to all sorts of problems. And there's some really important myths about diabetes that are really important to know. So it is a myth, meaning it is false, that diabetes only happens in obese people. That by not taking diabetes medications, or that it means that it's less serious, probably it's more serious because you're not paying attention to it. That type 2 diabetes is better than type 1. So diabetes and macular degeneration, there's a lot of commonalities. And one is, if you say which is better, type 1 or type 2, neither. And if you say with macular degeneration, which is better, dry or wet, the answer is also neither. Diabetes is not hereditary. That is also false. It absolutely is. Type 2 people with type 2 diabetes don't lose vision. That is also false. And probably most importantly, that if you have diabetes, I will know if my diabetes has damaged my eyes because of my vision. I will have symptoms. That is also very, very false. Oftentimes people have really bad problems in their eyes from diabetes or macular degeneration, as it turns out, and have no symptoms at all. Which is why you'll hear me say several times how important it is to have routine eye care, even if you feel as though your vision is great and you don't think you have any problems. Routine eye care is super important. So that really leads into the first really important message, and that's that good vision on an eye chart or in daily life does not mean healthy eyes. It means you have good vision today, but that doesn't tell you anything about what your vision will be tomorrow. Your eye health is what will dictate what your vision tomorrow and in the future will be, not what your vision is today. So what I want to talk a little bit about is what's called diabetic retinopathy. The retina is the inside, the layer, kind of the film inside the eye. And it has lots of tiny little blood vessels. And the problem with diabetes is it affects the tiny blood vessels in your body. And really the three places where you have the most tiny blood vessels are in your retina, in your kidneys, and in your brain. And those are the three places that diabetes is most likely to have negative effects. So, really important to know that diabetic retinopathy, so changes to the retina from diabetes, it remains the leading cause of vision loss in working age Americans, versus macular degeneration is the leading cause of vision loss in older age Americans. Many patients with really bad problems from diabetes don't know it, and they see great until they don't. It's kind of like you think, oh, I'm healthy, I'll never have a heart attack. You are healthy until you have your heart attack, and then it can be bad, right? Same thing with diabetes and diabetes-related eye problems. So for someone that has diabetes, it's really important to have eye care at the intervals that are recommended by either your eye doctor and or your primary care doctor or endocrinologist. Now this is a picture of the inside of someone's eye, and this is someone with a big hemorrhage in their eye. And I understand you don't totally understand what this is or what it means, but the idea here is that this probably wasn't there yesterday. And yesterday this person saw great, and today they woke up and all they see is a big blob of red and they don't see anything. But if they'd been to the eye doctor a day, a week, a month ago, they would have seen there were changes where treatment could have prevented this. So it's really important to know that severe problems in diabetes almost always can be prevented through early detection. Again, very similar story in macular degeneration, that if you know you have it and you're seeing your eye doctor and you're taking appropriate steps, oftentimes you can avoid vision loss. So why don't people with diabetes get annual eye exams? Well, the reason is most people with diabetes, or many people, don't understand the importance of why they need to get their eyes checked. So who's most likely to get these changes in their eye? Who amongst people with diabetes? So the longer you have diabetes, the more at risk you are of having complications from it in your eyes or elsewhere. People that don't take good control of their diabetes are at much greater risk than people that have really good control of their diabetes. People that don't control their high blood pressure or that don't control other conditions they have are more likely to have problems in their eyes. And so another commonality is that people that take good care of themselves with their diabetes are less likely to have problems. And as it turns out with macular degeneration, people that take better care of themselves, whether it's through diet, exercise, weight loss, not smoking, people who do all those healthy habits are less likely to have eye problems. So again, another commonality between diabetes-related eye problems and macular degeneration eye problems is that if you stay or become more healthy, the likelihood of having vision loss or vision issues is much less. If somebody has diabetes, you will understand this slide. If not, one of the things that people with diabetes watch is what's called their A1C. That's what's your average blood sugar over the last 3 months. And what we know is that just by improving it a little bit, you improve or decrease the risk of problems by a lot. So it doesn't always take huge changes to make big differences in how well you do. You may have seen TV commercials for something called a continuous glucose monitor, or you may have seen people with these little patches on their arm. That's something that checks their blood glucose all the time and allows someone to have way better control of their diabetes than someone that's pricking their finger, which is way better than people that never even do that at all. Because if you don't know what your blood sugar is, you don't know how to control it. So if you have diabetes, I would encourage you to ask one of your doctors about a continuous glucose monitor. Okay. And that's just what it could look like. It could be on your abdomen or it could be on your arm. And just by wearing one of these, people's control of their diabetes improves as much as by taking an extra medication. So that's why this is something that if you have diabetes, it's worth asking about. It helps control your condition. And just like with A1C, just a little bit of an improvement here in this time and range, and when you use this monitor, creates huge decrease in risk of having problems with your eyes or really anything else. Is there a link between age-related macular degeneration and diabetes? I'm going to ask a question like this, and the answer is probably yes, and there really is. And really, it's diet related. The same type of diet that's far better for diabetes is far better for macular degeneration. And so the commonalities just keep on coming between these two conditions, and the things that we can do to help decrease risk for one will decrease risk for the other. There's nothing that you can do that will decrease your risk for diabetes complications that creates more risk for macular degeneration. So anything you do to help you in one helps you as far as both are concerned. Whether it's diet or some of the same supplements, a little bit of exercise, all these things are really good for both. Now, people with diabetes are oftentimes unaware of how important it is to have regular eye exams and regularly having their eyes dilated, and don't realize that they can have problems without symptoms. I know I've said that several times, but it's super important. So if you have diabetes, how often should you get your eyes examined? Does anybody want to take a guess?
3 years.
I've heard twice a year, every 6 years, every 6 months, once a year. So here's the right answer. Ready? As often as your eye doctor tells you you should. That's the right answer. Because some people once a year is fine. And I have some people that I see 3 or 4 times a year. I have other people that are going to a retina specialist and they get seen once a month for treatment. So everyone's going to be different. If you don't get your eyes checked to know how often you need to get your eyes checked, then you don't know how often you need to have your eyes checked. So, if you have problems from diabetes in your eyes, what are the symptoms? Well, the main symptom is nothing, that you just don't know it. Now, in some cases, because most people with problems from diabetes in their eyes have really good vision. By the way, just like most people that have macular degeneration have really good vision until they don't. Now, some of the symptoms that people might have, whether it's diabetes or macular degeneration as it turns out, are little blind spots in their vision, discoloration to their vision, things that are supposed to be straight lines look wavy or distorted, colors look off, things that become more blurry than what they used to be. But again, the most common symptom is no symptom. That's the most important thing I could tell you as far as that is concerned. What's the treatment? If you have diabetes-related eye problems that require treatments, here's another commonality between this and macular degeneration. The most common treatment are eye injections. The same medications that are used in macular degeneration. So same medications, given the same way through an injection, is done in the office. How many of you have had an injection into your eye? Okay. How many would say that it hurt as badly as you assumed that it would? Just one. All right. So for most people, the worst part of getting an eye injection is the thought of it, of knowing what's coming. The actual procedure for most people, if it's done right, it should not hurt at all. It shouldn't hurt at all. So it sounds gruesome and terrible, but for most people, it's fairly easy to go through. Now, if you have diabetes and you go to see your eye doctor, what should you be asking your eye doctor? Number one, do I have diabetic retinopathy? So is diabetes affecting the inside of my eye? If yes, how severe is it? Just so you have an idea. And when do you want me to come back? Do I need treatment? Or when do you want me to come back? And then will you send a report to my primary care provider or my endocrinologist? It's really important there's correspondence between the two. Now, for people with diabetes, what can you do to help your doctor do a good job? Number one, know your A1C, so know about your blood sugar control, because that helps dictate risk, so we kind of have a better idea of what we're looking for. Bring a list of your medications, because different medications affect your risk of having eye problems. Be prepared to have drops put in your eyes and have your eyes dilated, and this one's going to sound silly, but I can't send a letter to your doctor if you don't know who it is. If you can't tell me who your doctor is, I can't send them a letter to let them know how your eyes are doing. It happens all the time where I'll ask a patient, who can I send a letter to for you? And they say, my doctor. And I say, well, who is that? Well, can't you find it in your system? No, there's no magic system that tells me who your doctor is. So you need to know who your doctors are. And then, by the way, when you go to your regular doctor, you need to know who I am, who your eye doctor is, right? So that they can correspond with each other. They want to know what I find. I want to know what they find, because it helps me take better care of you. All right, so just to review a couple things. Most vision loss from diabetes can be prevented with appropriate examination and treatment. Vision's usually good until it's not, so don't wait till there's a vision problem. Are there other problems that can happen in your eyes besides this retinopathy that I'm talking about? Yes, there's many other conditions that are more common in people with diabetes, but really the most important is what I mentioned to you, diabetic retinopathy. How do you find a great eye doctor if you have diabetes and you don't already have an eye doctor? It could be an optometrist or it could be an ophthalmologist. Ask a friend, ask your primary care doctor. Who do you share patients with that you get good correspondence from so that you can take care of me together? And then when you call the eye doctor's office, it's okay to ask them, hey, do you regularly see people with diabetes? There'll be some eye doctors that'll say, you know what, that's not my jam, here's who you should go see instead. If you call my office, there's certain things that I like to do that I think I'm good at, and there's certain things that I don't like and I'm not good at. And I'd rather tell you that, I'd rather you ask me. So it's okay to ask an office, is this something that you do? Okay, so key messages: make sure that you or your loved one with diabetes has routine eye care as frequently as their eye doctor requests of them. Here's a couple really good resources. Your doctors, whether it's your primary care, your endocrinologist, or your eye doctor, optometrist, or ophthalmologist, can be a great resource about diabetes. The American Diabetes Association has a great website. They have part of it that is for patients, part for doctors, so go to the patient part, and there's fantastic information. And then I really like this book. It's called Diabetic Eye Disease, Lessons from a Diabetic Eye Doctor. And it's written by a guy who's an optometrist who's had diabetes for 50 years. So he has kind of a unique insight into how can what do you need to know as a patient from a doctor's view, and him having both those views. So that's something that if you or a loved one has diabetes, I would highly recommend. That really helps you understand what's going on. All right. So I know we're going to have time at the end for questions, but if anyone has any real quick questions about diabetes, I'll take a couple. Yes?
If you're going to a retinal specialist once a month, do you need to go to another optometrist or anything like that for a checkup?
That's a great question. If you're going to a retina specialist once a month and getting injections, then you need to still go see an optometrist. The answer is yes. Here's why. It's kind of like if you go to a foot doctor, do you still need to go to your regular doctor to listen to your heart and do your general medical care? The answer is yes. Because a retina specialist doesn't check you for glasses. A retina specialist may or may not check for things like glaucoma or dry eye. So I would think whether it's an optometrist or an ophthalmologist, it's kind of like your primary care provider. They're the ones that do all the general care. The retina specialist is just doing very specialized care. It's a really good question.
Thank you.
Sure. Oh, you were waiting for her. Oh, that's good. All right. Any other diabetes-related questions?
Could you repeat the website again, moving forward?
Yep. So the two websites that I'll point out are for the American Diabetes Association. So that's diabetes.org. And the other one that I didn't mention, but there's one called diabetesincontrol.com. And that just has good medical articles if you want to see what's new in diabetes. And then the book I mentioned is called Diabetic Eye Disease, Lessons from a Diabetic Eye Doctor. All right, so now we'll move on to macular degeneration. Let me reset my timer. All right, so I know this is what most people really came to hear about. First thing, if you have questions or want to hear or see things and you're not here in person, you can go to our website, macularhope.org. It is a fantastic resource for anything from recordings of things like this to 1 or 2 minute short videos on what is, and having an eye doctor answer questions, just very short, succinct answers. There's part of it that's what's in the news, and so anytime I read about new stuff in macular degeneration, I'll try to send it to Donna, and normally Donna says it's already on the website. So it's a great place to see new information as it comes out. So macularhope.org.
What
So,
is that middle word, macular what?
Macular Hope.
Hope, H-O-P-E.
Yep.
.org.
.org. Exactly. So first, real quick, just a very quick little anatomy lesson so you understand where the macula is, right? Because you hear macular degeneration, but you may say, well, what is a macula? Where is it? So here's an eyeball. The macula is smack dab in the middle when you look into the eye, in the back of the eye. And really the best way I can describe, kind of what or where the macula is it's the bullseye on a dartboard. Anywhere you hit a dartboard, you get some points. But if you hit it right in the bullseye, that's where you get the most points to win a game, right? When light goes into the eye, and you're using parts of the back of your eye to see, the retina, the inner layer of film, is kind of like a dartboard. Wherever light goes into the eye, you have some benefit from. But the macula is that bullseye. When you're able to use that properly, that's how you really see things clearly. Okay, so when you look at things, you're using the macula. And so when it's damaged, when it's irregular, that's when we don't see as well. The other analogy I like to use is to that of a camera. And by camera, I mean something that you all understand but your grandchildren don't. I don't mean the thing that you carry in your pocket and take out and talk on. That's called a phone. So when I say camera, I actually mean like an old school camera with film, right? We all remember those? So the different parts of a camera really equate very nicely to the different parts of your eye. The retina is like the film in a camera. The macula is like the center of a picture that you take. It's right in the middle of each frame of film. And part of the reason why that's important is because if you have bad film in a camera, it doesn't matter how much you focus the lens, you don't get a good picture. And that's why sometimes if we have macular degeneration or other eye conditions, glasses may not help. Because if the problem is with the film, you can focus all day long and still have a problem with the film. If the problem is macular degeneration, glasses may not do much good. Now what may do more good than glasses is low vision, using different types of magnifiers or other things to help you utilize your vision as well as you can. And so my analogy for that is like putting a zoom lens on your camera. So you put a zoom lens on the camera, you can make things really big. And it might make it easier to see even if you have a film problem. And that's why sometimes magnifiers can be so helpful, but also why sometimes just changing glasses might not be helpful. Because that's a question I hear all the time, well, can't I just get stronger glasses? Stronger isn't better. The right power is the right power. Too strong doesn't work, too weak doesn't work. So glasses may or may not always be the answer. So again, the macula is like the bullseye on a dartboard. It's in the very center of the retina, the center of the layer in the back of the eye. What is macular degeneration? So age-related macular degeneration is kind of what the name says. It's a degeneration of the macula, that's that bullseye, that comes with aging. It's obviously something that can be scary, can lead to anxiety or depression, both of which are really common. For some people, it can take away vision. For some people, by the way, it never really bothers the vision. So not everybody that gets macular degeneration loses vision or loses the ability to function. And that's really important. What I tell my patients is nobody goes blind from macular degeneration. You just don't. It's impossible. Now, you can become legally blind, and that's different. Legally blind pertains to how well you're able to function. But blind means close your eyes, cover them, and turn out the lights. That's blind. And that never happens for macular degeneration, and that's a really important point. Because if you don't know that, that's what you think is going to happen. Now, you could have something else that's wrong that could lead to other problems, but macular degeneration on its own never leads to blindness. Realize it's a condition for which there's lots of support for patients. Tucson Society of the Blind is here, organizations like Macular Degeneration Association, and there's plenty others. So it's not something that you have to go through on your own without help. Many of you probably have seen or used one of these grids. I don't like them, and I'll explain to you a little bit later why. You'll see a video why, but you need to be doing something to monitor your vision, because if there's a change in between visits to your doctor, you need to go in. If you have macular degeneration, your eye doctor says, we'll see you in 6 months, That doesn't mean if your vision changes in 1 month, wait 5 more to come in. It means hopefully in 6 months you'll still be okay. But what should always be said is, but if there's a change in between, we want you to let us know because we'll see you right away. So noticing changes in vision are important because if we don't catch those changes in vision, if we do catch them, oftentimes they can be treated. But unfortunately, if they're not treated, then oftentimes they can lead to negative impact on your overall quality of life. So what causes macular degeneration? So the main things are age and genetics. 2 things that you can't really control. But the things that you can control are, do you smoke? Are you obese? Do you have a healthy diet? Do you take care of yourself in general? Cardiovascular disease, high blood pressure? Do you exercise some? So when it comes to macular degeneration, I already mentioned that some people ask which is better, dry or wet? Do I have the good kind? There is no good kind. You don't want any kind of macular degeneration. You may know somebody that's gone blind from AD. We already dispelled that myth. Nobody goes blind. You may lose function. You may need to go to an eye doctor once a month, but nobody goes blind from macular degeneration. And by the way, you probably wouldn't know if someone in your family's lost vision because of macular degeneration. I said it's a lot of genetic predisposition, but a lot of times we don't know if someone in our family has vision problems, or if they do, why. So it's important to, for example, if you have macular degeneration, let your kids or let your grandkids know so that they can know to be on the lookout to start having healthy lifestyle habits. All AMD starts out as the dry form. A word your doctors will use is something called drusen. So if you have dry macular degeneration, drusen are like little bumps under the film in the camera. And so if you have little bumps under the film, if they're small enough and spaced out enough, they may not affect the picture. But if they're big enough or close enough clumped together, it may affect the picture the camera takes, just like they may affect your vision. Sometimes dry macular degeneration progresses to the wet kind. That's considered advanced macular degeneration, and it can, should, and needs to be treated. The other form of advanced macular degeneration is what's called geographic atrophy, for which you're now seeing commercials on TV about. Vision loss can occur with either dry or wet macular degeneration, so nobody's safe. So that's why there's not a good kind, but there's things we can do to be preventative regardless. How common is macular degeneration? So leading cause of legal blindness in people over age 50. 90% of the time it's dry, only about 10% of the time it is the wet kind. There's about 11 million people in the United States that have macular degeneration, so it's pretty darn common. Over 1 million people have the wet kind, over 1 million people have the advanced dry kind called geographic atrophy. There's probably somewhere around 250,000 people in the US that are legally blind because of macular. So by the way, what is legally blind? You know the big E on an eye chart? Legally blind means you can't see that. Okay? So it means when you're in an exam room under certain conditions, a certain size letter, you don't see it. That doesn't necessarily mean you can or cannot function to do certain things. So what's more important to me about people is how are you functioning? How are you getting along with the things you want or need to be able to do? All right, have you heard of glaucoma? Most of you probably have, right? Macular degeneration is 3 times more common than glaucoma is. Does everybody here know what genetics is? Probably. Genetics is the biggest driver of macular degeneration. About 70% of who gets macular degeneration is driven by genetics. So that's why knowing at least a little bit about family history is so important. So I'll ask the same question I did about diabetes. What's the vision for people that have macular degeneration? Well, for most people it's great. It can be 20/20, which means really good vision. And some people it can be really lousy. And it can be anything, anywhere in between, whether it's dry or wet. It can be really good vision, it can be really poor vision. So just what your vision is doesn't necessarily tell you, is it bad, is it not, do I need treatment, do I not need treatment? But what's really important to know is if you eventually are told, well, you need to go get your wet macular degeneration treated, the best predictor of how well you'll do with the treatment is what your vision is when you start treatment. Meaning if you catch it early and get treated early, then it's likely that you'll continue driving, reading, and doing all the things you want long term. But if you don't go to an eye doctor until you say, well, I covered this eye up and I couldn't see very much at all, and that's when you get your first treatment, then that eye likely won't end up seeing very well. So similarly, if you have macular degeneration, how often do you need to get your eyes checked? As often as your eye doctor tells you that you need to. Again, I have some people that I see once a year, twice a year, 4 times a year, and there's other people that get injections once a month. So there's huge variation. There's not just one standard. Earlier I used the word drusen. The only reason I use that as a medical term is because oftentimes doctors use that and throw it around in an exam room and they pretend like you know what they're talking about when you don't. So these little colored spots, like the little bumps under film, those are what's called drusen. Some people just like that word, I don't know. Okay, so one of the tests that your doctors will likely do is something called OCT. This is basically a very fine-tuned ultrasound of your macula. Those drusen I was talking about, those little bumps. So this little dip is the macula, and these little bumps are the drusen in the macula. So this is what I would commonly see in a patient that has macular degeneration. If you have macular degeneration, your eye doctor will be doing this. It's just something you sit in front of, they press a button, you see a little bit of a light, it's not even that bright, in a second it's done. So it's a super quick, easy test, but it's necessary. If someone develops the wet kind of macular degeneration, unfortunately, it can change and vision can change pretty rapidly. So again, that's why it's important to be paying attention. Can macular degeneration be cured? Does anybody want to hazard a guess at this? No, not yet, it cannot. Will I eventually go blind? No, good, you're listening. But you may need a lot of eye care. What about, can I keep the vision I have now if I develop macular degeneration? Yeah, with the help of your eye doctor, especially if you catch it early and do appropriate monitoring. Most people, not everybody, most people can keep their vision fairly close to what it is when they find out, which is good. So what are the things that we need to do to help be preventative? They're all just very general, healthy lifestyle habits. They all sound easier than they are, by the way, but 4 very generally accepted lifestyle habits. So number 1, don't smoke. Number 2, proper diet and or nutritional supplements are really important. Exercise, and I'll touch on that, what that means, and then just general health care is helpful. Smoking is super important. That's the most important controllable thing. If you smoke, smoking's bad for you, and it's bad for your macular degeneration. I never tell someone it's easy to quit, but it's the most important thing to try to quit. Yes?
You skipped twice over that thing that says sun.
Yeah, because I don't really think that. So there's no study that says that UV light in particular causes macular degeneration. There's nothing wrong with UV protection, but by the time you're worried about macular degeneration, you've already gotten the vast majority of UV into your eyes that will ever get into your eyes. So it's not of zero importance, but of all the things that are up here, it's of the least importance. So sunglasses are not a bad thing, but that shouldn't be your primary thing that you're doing. And by the way, if anybody wants to go join Gospel Hour, it is next door. I know, I'm pretty boring in comparison, so I apologize.
Don't tempt me.
I'm just giving you choices.
Okay.
So smoking's bad, okay? It's interesting, most people with macular degeneration that smoke will say they didn't know it was bad for them and that no one told them it was bad for them. Now, that might just be denial, but smoking's bad, okay? Probably didn't need me to tell you that. What should I be eating? Well, just to say a healthy diet doesn't quite cut it. So I try to have 1 or 2 line answers for everything for my patients. So my 1 or 2 line answer for this is more green leafy vegetables, less refined carbohydrates. Another one could be try to eat more real food. Things that actually come from the earth that are not manufactured in a building. Right? So less ingredients equals more like real food, better for you. Okay? If you say, well, what type of diet is the best kind of diet? Mediterranean is. Is it okay to have a glass of wine? Sure. It's more than okay. It's actually good for you. 1. Yeah, 1. Like 7 isn't 7 times as good as 1. Just so you know. A little too excited. Okay, so I mentioned exercise. And so my line to my patients about exercise is just do something. You don't need to run marathons or pump iron. And the reason is there's a study that showed if you walk one block, if you have macular degeneration and you walk 1 block a day, you decrease the risk of developing the wet macular degeneration by half. 1 block a day. Now, I don't know if that means walk from here to the end of the block and take an Uber back. But that's not the point. The point is just do something. So even if you use a walker, maybe you don't go for a walk, but you do something just to raise your heart rate. Just do something. Okay? So don't be fooled into thinking that if you're not walking 3 miles a day or 10,000 steps or this or you don't need to. Just do something. Whatever that something is better than nothing. So yeah, my line is, you don't need to pump iron or run marathons, just do something. What vitamin should I take? Whew. I could talk about that for an hour. And if I were talking to a group of optometrists, I could easily talk about it for 2 hours. Okay? Ask your doctor. The healthier your diet, the less you're going to need a vitamin. There's a certain stage of macular degeneration, it's called intermediate dry macular degeneration, that you need to be taking what's called an AREDS 2 vitamin. Okay? And so your doctor may have told you that, but I would ask your doctor, your eye doctor, what vitamin would you recommend? If you have macular degeneration and they say you don't need to take any vitamin, you need a new eye doctor. Okay? Usually, so again, the AREDS 2 for a certain stage. Other than that, there's lots of choices, there's lots of good choices. Ask your eye doctor, that's the best place to get the best answer. Some people do genetic testing to help them know how likely it is for their macular degeneration to get worse. That's available to you. I already mentioned eye vitamins, really important if you have macular degeneration. You need to be on an eye vitamin. If you're not, ask your eye doctor. If they tell you you don't need it, find a new eye doctor. There's home monitoring you should be doing. So most of you are probably familiar with that little grid with the little lines on it called an AMSA grid. I don't like that because I think most people don't do it correctly because it needs to be done 1 eye at a time, held at a certain distance without moving it, and do it right. Anything other than that is worse than not doing it at all. So you'll learn a little bit later about a digital home monitoring device that for people with intermediate dry macular degeneration, so a certain stage, that your doctor would be able to tell you if you have, that is far more beneficial than an AMSA grid, and for most people it costs the same as an AMSA grid, which is nothing. Alright. So, important to know that poor vision, if someone detects their macular degeneration later on, can be a source of depression and anxiety. 40% of aging patients are affected by depression because of their poor vision. So this is something that people should be aware of. Similar numbers for anxiety. So it's pretty common. So it's something important to be able to talk to people about. Whether, again, it's through a group like Tucson Society of the Blind, or some other support group, or friends, or your doctors to find someone else to help you. It's important to realize that this is pretty common. I already mentioned this grid that is, I would say, sometimes better than nothing. It's worse than nothing if you do it incorrectly. So if you're going to use a grid, make sure to ask someone or read about how do I do it correctly. This is the digital device that I recommend to all my patients that qualify for it, that we'll hear a little bit more about later, that is far more sophisticated and works far better than an AMSA grid. But again, this is for people with a certain stage of macular degeneration that you can find out about from your doctor. What are the symptoms of wet macular degeneration? So if you develop wet macular degeneration, some people have no symptoms until they do. And then once they do, it can be anything from very mild to really severe. So again, we can't count on just what's our vision to know if we need help. But symptoms may include things getting blurry, lines getting distorted, the center of my vision not as good as what it used to be. What happens is this is trying to depict that this is all supposed to be flat. These are blood vessels in a space where they're not supposed to be, kind of creating a bubble or blister, and that's what happens when you have wet macular degeneration. All right. And so this is someone that looks similar to the picture I showed you with the person with the changes from diabetes, where blood develops in an area where it's not supposed to be. And so if you have film and a camera, and then you smear blood on top of it, well, you're not going to get a good picture, because the blood is blocking the light from hitting the film. And that's the same thing as what happens if someone has wet macular degeneration. Besides that OCT test I showed you, that colorful thing, sometimes doctors will do a test where they inject dye into your arm that goes through your body that shows where there's leaking blood vessels in your eyes. So that's something that generally just a retina specialist would do. They don't do it very often, but I just tell you about it so that it doesn't sound crazy if you go to a doctor and they say, oh, we're going to inject some dye in your arm to look at your eyes. Because it sounds kind of weird if you don't really know what it is. So what I'm going to show next are 2 short videos of people getting injections in their eye. So if you've had it done already, you can see what's happening to you. If you've never had it done, you can choose to watch, or I'll tell you when it's over. Okay? So if you don't want to watch, just close your eyes. First is the one on the top. And this is like the world's fastest injection. It's hard to believe it's even real. So they're just telling this guy, okay, look over to the side. Here we go. Injection done. Crazy, right? Now this next one takes a little bit longer.
Hey, this is Albright, and I'm going to get it.
Yeah. So this guy talks through it. He's kind of annoying. But so what this is showing is they're putting a drop of what's called betadine that kills off bacteria or other bugs in your eye. So that's basically to cleanse. The eye's already had a drop of anesthetic, so it's completely numb. And there they go. They're doing the injection. This is more like real speed, I think, for most people. Done. Another drop of the betadine. That's it. So that's how quick it is. Now when you're having it done, it seems like it takes like 7 minutes, right? But retina specialists that do a lot of these will do like 50 in a day, so trust me, it doesn't take 7 minutes. It's quick, it should be painless. As a patient for you, it should be easy. There are multiple different medications available. Really important to touch on something called low vision. So I've already mentioned that sometimes people do lose some vision because of macular degeneration or diabetes or something else. Low vision is when you're not able to have your vision corrected through more traditional means like glasses or contacts or even cataract surgery, and you use things like magnifiers, digital devices, or all sorts of other things to help you be able to function. And it makes a world of difference. It's something that too oftentimes eye doctors don't bring up. So if you have an eye condition and glasses aren't helping, you need to ask your eye doctor, can you refer me to someone that does this? Most eye doctors don't. In Tucson, there's probably like 2 people that do it, if that many. So it's not real common, but it's something that's definitely needed. All right, so I'm going to skip that to go on to the next part about macular degeneration, some new treatments and innovations in macular degeneration. You can look up about clinical trials. I need to change that, that's not yellow, but it says clinicaltrials.gov. You can go there, you can type in macular degeneration, you can type in Arizona, and you can find where in Arizona are there clinical trials being done on macular degeneration. Oh, Dusty's changing it right now. He's messing with me. Oh, that made it a little better. So clinical trials usually you think of as I'm a guinea pig. Usually you're not. Okay, so most of the clinical trials that you'll hear about or have the opportunity to get in are trials where it's what's called phase 3. Phase 1 means we got to find a guinea pig. Phase 2 is we didn't kill the guinea pig people. We think it's going to work, let's try it in like 50 real people. Okay. Most of the things you actually hear about or have the opportunity to get into are what's called phase 3 trials that involve hundreds if not thousands of people to ultimately prove whether something works or not. If it gets to phase 3, a company's already spent $1 billion and they're pretty sure it's going to work because they're going to spend another $1 billion to get it approved. So you're not a guinea pig quite like what you think. Stem cells. There's no approved stem cell treatment in eye care. Don't do it. There are doctors that will tell you they can inject stem cells in your eye. Doesn't work, no proof, don't do it. There's an NEI, National Institute funded study, that's different, but in general, there's no stem cell treatment for your eyes at this time. Here's a list of things I'm going to touch on each of them for just a minute or two. Number 1, realize there's hope. There's dozens of medications and trials for macular degeneration. There's been half a dozen new approvals in the last 18 months for macular degeneration. So there are more choices today than 2 years ago. It's a really common disease, which means if a company comes up with a good treatment, they make a lot of money. So there's companies actively looking for not cures, for treatments. PreserVision AREDS 2, that is the most prescribed eye vitamin. It's over the counter. If you have intermediate dry macular degeneration, this is something that there's over 20 years of clinical trial, over 8,000 people in trials that shows this is what you need. The least expensive place to buy it is at Costco when it's on sale, and like every third or fourth sales cycle, it's on sale. Or you can get coupons through the manufacturer, where you'll get more coupons that you can never use. So it certainly can be affordable. That's for intermediate dry macular degeneration. So certain stages where it's proven to be beneficial. Genetic testing can be helpful to know what your risk is, as far as who's more or less likely to ultimately develop wet macular degeneration. If that's something you're interested in, ask your eye doctor about it. Are there genetic-based treatments? And so in clinical trials, there's treatments that are using genes and gene-altering therapies to basically change the genetics of the cells in your eye to make them medicine factories. So I talked about the injections into your eye to treat wet macular degeneration. So what companies are trying to do is take a virus, inject it into your eye to infect the right cells in your eye, and infect them in a way to where they make the medicine. And so you have the treatment once, and then you have a medicine factory in your eye. Sounds like crazy science fiction, but it's real life stuff. It's not available yet, but that's what's in clinical trial. Newly approved, there are 2 newly approved treatments for what's called geographic atrophy. If you watch TV, you've seen commercials for this. So have any of you seen the Fonz on TV talking about macular degeneration? That's what he's talking about. Have any of you seen the, I think, ridiculous commercial of people your age painting weird animals on their faces? That's for one of these 2 drugs. So by the way, I figured out this morning, literally this morning when I went to work out, I saw the commercial, I figured out what they're doing. So I used to say it's a bunch of senior citizens on hallucinogenic drugs that got together and painted their faces. Which may still be true. But what they're painting on their faces, there's 3 animals. One's a turtle, one's a sloth, and I don't remember what the third one is, because they're all pretty silly, but turtle, sloth, and the other animal is another one that's really slow. And so what they're implying is you can slow the progression of geographic atrophy. Snail, yeah, snail. So by painting a snail on your face, you slow the progression of geographic atrophy with these drugs. I know you're all gonna go get snail tattoos. Please, no, don't go get snail, sloth, or turtle tattoos. That will not slow your macular degeneration. This is a medication that is also fairly newly approved that can, for the injections, instead of needing them every month, the majority of people can go between 12 and 16 weeks in between injections for their wet macular degeneration. So same treatment as others, same type of drug, but works differently, so it's much longer in between injections. This is a drug that's been out for years, but they decided to try it at a different strength or concentration and found the same thing. The majority of people can go between 12 and 16 weeks in between injections and not every 4. Injections aren't that bad, but if you have to go every 4 weeks, it's a pain in the neck, right? It's a burden on you. And it's a pain in the eye, yeah. But it's actually not a pain in the eye. But if you change that from every 4 weeks to every 16 weeks, it's not nearly as much of a burden. So that's the benefit of these new drugs. It's not that they work better, it's that they work for much longer. And so that's hopefully an improvement in quality of life. There's this little thing that's a little port that goes into your eye. Then instead of getting an injection every 16 weeks or 12 weeks or whatever, you can have a surgery to put this little port in your eye, and it slowly lets medication out over the course of 6 months. And in trials, it worked great. It was approved in October of 2020, or in January of 2022. In October of 2022, the FDA pulled it off the market because of some problems. And then last month, the FDA reapproved it. The problems got fixed. So this is something where you could potentially go and only need to have something done once every 6 months. So again, another huge potential improvement. At-home monitoring, this is something that was approved by the FDA last month. So if you have wet macular degeneration, the way to really know how often you need injections is when there's change in your eye. And so there's actually an instrument you can have at your house. That OCT I showed you the doctors use, you can have one at your house. And it will tell you, or you'll tell your doctor when you need your next treatment for wet macular degeneration. It's really cool high-tech stuff that, again, just within the last month was approved. If you go to your eye doctor on Monday and you ask them about this, I mean, you'll impress the heck out of them, because I bet you most eye doctors don't even know about this. It's brand new. Stem cell already talked about, nothing yet. It's research only at this point. Oral medications, right now there is not an oral medication for macular degeneration. It's important to know that aspirin doesn't make it worse. So if you're on an aspirin today, keep taking your aspirin today. We don't yet have an oral treatment for macular degeneration, but wouldn't that be great? So there are companies that are looking at that. The other thing that I'm hopeful for is there's a light-based therapy, where it's an instrument that shines certain wavelengths of light at your eye, and if you have dry macular degeneration, it can actually improve it. So it can help you regain some vision and make you less likely to get worse. So this would be an in-office, in your doctor's office treatment. It's not a one-time thing. It's 3 times a week for 3 weeks, 3 times a year. So you need kind of ongoing maintenance, or at least that's what the studies looked at. But no needles, and it stabilizes or improves dry macular degeneration. So not available in the US yet, it's available in Europe. Hopefully it'll be available here soon. Topical medications, nothing yet, but there are companies looking at this, because again, wouldn't it be nice? It'd be much less burden on you and doctors, quite frankly, if the treatment was an eye drop and not needing to get an injection. So nothing yet, but there are companies that are doing trials at that. All right, so that's what I have to say about macular degeneration. Don't clap yet. So what we'll do is just a minute or two of questions, because then what we're going to do is Tucson Society of the Blind is going to take a couple minutes to tell you a little bit about them, and then after that we'll take a quick break, and we have a Q&A session later. So just a couple quick questions. Yes?
So, my understanding is that, interpreting most of what you said, except for certain lifestyle changes, there's really not much you can do. You can just try, and you can take some vitamins.
Correct.
Is it inevitable
No, so it is not inevitable that you will get wet macular degeneration. Most people do not. Okay, so most people do not. So the changes that you bring up, the lifestyle changes like diet, exercise, smoking, supplements, all those healthy things are important to try to keep it where it's at currently. So you don't want you don't want the dry to become worse, nor do you want it to become wet. But you're correct that right now there's no drug, there's no prescription pill to take, there's no injection, there's nothing like that. The light therapy may be something that can be done to slow or reverse it some, but that's not available yet.
I also
Secondhand smoke is not as bad as being the smoker, but it's not good either.
I had ophthalmologists. I go to a retina specialist. For some reason, they seem to be more about stuff down the line.
Yeah, so the way to look at different eye care providers is, so most people with macular degeneration that require treatment will be going to a retina specialist. People that can diagnose your macular degeneration or follow it can be an optometrist or a general ophthalmologist. But generally when it comes to treatment for it, that'll be done by a retina specialist. All right, one more, and then we'll move on, but I promise we'll get to your questions. Yes?
What is the difference in certification for a retina specialist compared to an ophthalmologist?
Yeah, so a ophthalmologist goes to undergraduate, 4 years of medical school, 4 years of ophthalmology residency. A retina specialist then does an additional year after that, just retina. And so a retina specialist doesn't do cataract surgery, doesn't do what you need for glasses. They just do things like macular degeneration or how diabetes affects your eyes. That's all they do. Yeah, designation is the same. Wow, they got their microphones. So for this song, we're going to call on Tucson Society of the Blind to come up and tell us what they're going to tell us. Because I'm not going to fight with the good pastor next door.
We've asked them to turn it down.
Thank you.
Okay, good morning. My name is Barbara McPherson, and I'm with Tucson Society of the Blind. All right, we have a table in the back, so be sure and stop back there. We have a resource list, we have a brochure, and we're also selling Jim Flick raffle tickets. Yeah. All right. It's really important to find a group that you can talk to. And that's what we are. We're a resource group. We help people find the resources they need. We meet every week at the church at Christ Presbyterian. Right now, we're going to be on the phone. Our website is www.TucsonSocietyOfTheBlind.org. So that website again is TucsonSocietyOfTheBlind.org. Alright, I've got to tell you a joke. Why do blind people not do skydiving? Because it scares the guide dog. Okay, now I want to mention there are a lot of non-technical things that you can be doing that will help you. One of my favorite tips is with the toothpaste trick, we call it. You don't no longer put toothpaste on your brush. You buy yourself your own tube of toothpaste and you squeeze it right in your mouth. So then there's no chance of dribbling all over the place. We also use the iPhone. It's one of the greatest tools you'll ever get. Our favorite app is called Be My Eyes. It's a completely free app, and you put it on your iPhone. All you do is aim your camera, take the picture, and let it come back, and it describes everything beautifully on what you're wearing. Anything you want to know, use your Be My Eyes app. The other thing that we do at Tucson Society of Blind, we have a lot of fun. We go on all kinds of social things. Right now, we're going to the Arts Express. We just went to the play Grease. We're going to be going to 9 to 5 and Disney Beauty and the Beast. And so what's nice about Tucson Society of Blind is that you're not alone. There are others to talk to. We pretty much know what's going on. And it's just a wonderful place to talk to other people that have vision impairment. Okay, any questions for me? Any questions? No hands? Okay, well I hope that you guys will visit us in the back and maybe buy a Jim Quick ticket. They're $25 each and you could win this wonderful, wonderful Jeep. The nice part of it is that all the money stays with TSP. Okay, thank you for your attention.
All right, thank you so much. So please, they are in the rear closest to the door. We have a hand waving in the background. If you can't see them, they'll be happy to assist you with any information that you would like to get about their organization, and we do encourage you to visit them. So this will help you in your journey with your eye disease. Otherwise, please take a few minutes, use the restroom, get a drink, maybe visit the church next door, see if you'd like to join in on that. But we'll be back in about 15 to 20 minutes, all right?
So for those of you that came up to me and said, why haven't you talked about dry eye? It's because you hadn't waited long enough, because here we go. So, and Donna asked you to fill out your survey forms. So when we did these, I told people I would stand on this side of the room, sorry. So last year, when people filled out surveys, we got a lot of surveys back that said, I wanted to learn about dry eye. So we started to incorporate dry eye into these seminars. So that's why it's really important, the evaluation sheet that you have, please fill it out. Especially if there's things that you say, well, I wish we would have talked about, put that in there. So when we come back next year, we can talk about those things. So we don't talk about things we don't know that you want us to talk about. All right, so a few very basic things about dry eye disease. Number one, it is not at all related to dry macular degeneration. You can have either one, you can have both, you can have neither. They're not related. Now, as it turns out, when people get a bunch of injections in their eye, a lot of times those betadine drops, those antiseptic drops, can cause your eyes to be a little dry, but it's not the macular degeneration. So the two are completely unrelated. Most of the time, dry eye can be controlled with, usually with eye drops. Again, with the help of your eye care provider to tell you which type of drops to use, whether they're over-the-counter or prescription. There's supplements. There's other things that can sometimes help dry eyes. Not all artificial tears are the same. And that is an extremely, extremely important point. That's probably the most important point I can make to you, because so many people use artificial tears. And I'll talk about it a little bit more in just a little bit, but they are not all the same. Super, super important. So I may not be able to stay, it didn't work, good. With dry eyes, there's a continuum from very mild to very severe, both in the signs, what your doctor will see, and in the symptoms of what you may or may not experience. Interestingly, sometimes I have patients, I look at their eyes, they look incredibly dry, but they say, my eyes feel fine. And so I explain to them, I say, is that a good thing or a bad thing? They say, I don't know. I say, well, if you have a gas stove top and it's on and you put your hand in it and it doesn't hurt, is that a good thing or a bad thing? It becomes a bad thing pretty quickly, right? So not feeling a problem doesn't mean it's not a problem. So sometimes if your eye doctor says, well, boy, you have dry eyes, I want you to do this, that, or the other for it, you say, well, my eyes feel fine, I'm not going to do it. Well, then it's likely to get worse to the point to where it does bother you, either the way your eyes feel or the quality of your vision. Dry eyes can sometimes be related to other systemic conditions or medications. Your environment can affect dry eye. So when you live in a place that's really dry, you're more likely to have dry eyes. When there's more humidity, you are less likely to have dry eyes. If you're always in a building or somewhere where you have very dry, cold air being blown at you, your eyes are more likely to get dry. Your doctor may use a formal questionnaire to see if you have dry eyes. Your doctor may just ask you very simple questions like, do your eyes ever get dry, red, or irritated? To then lead them to maybe do different testing to figure out what to do about your dry eyes. Yeah, they just turned the music up. And there's actually a nasal spray, a prescription nasal spray for dry eye. Yeah, that for a lot of people works really well. What causes dry eye? The reality is there's a whole bunch of different things that can cause dry eye, whether it's your environment, whether it's medications. There's not just any one thing that causes dry eye. So if you have dry eyes, what could your symptoms be? So I'll tell you the two most common symptoms. My eyes are dry, makes sense, or my eyes are watery, which makes no sense, right? So the reason they get watery is with our tears, there's two things that are important. One, that we have enough tears, that's quantity. The other is that the tears that we produce, that they work well enough, that's quality. If you have a whole bunch of something that doesn't work, then you'll probably make more of it. And it probably still won't work, and you'll probably then still make more of it. And that's why your eyes can actually be dry with watery eyes, because you're making plenty of tears, but they're not functioning the right way. So other symptoms, just general pain or discomfort, feeling like I have something in my eye, Light sensitivity, redness, or another big one is fluctuating vision. If your vision gets better when you blink, that's dry eyes. Cataracts never change in between blinks, neither does macular degeneration or virtually anything else. If you start reading, I'll sometimes have people say, yeah, when I start reading everything's fine, but after 10 or 15 minutes my glasses don't work anymore. The glasses didn't change, your eyes became dry. If you blink a couple times, does that help? Yes, you have dry eyes. So those are some of the general symptoms of having dry eyes. So I may go back, I apologize, I may go back to the other side of the room because this doesn't really work from over here. I'm trying really hard. What are some tests or things your doctor may do to help to find out if you have dry eyes? Number one, ask you questions. They'll likely use a kind of yellow-orange dye in your eye to help to see if there's any signs of dryness. Oop, let's go back one. They may use a little paper strip in your eye to detect how much tears, quantity you're making. Now they're turning up to try to compete. They may use a test to measure the inflammation or thickness of your tears. They may take pictures of the glands that produce tears. Or, you just say dry eye, it sounds super simple, right? But there's a dozen or more tests that your eye doctor may or may not do to help determine if you have dry eyes or what the cause of your dry eyes may be. So let's go to the next, So what this is so this kind of greenish colored dye on the eye is basically just coloring your tears. And when it's a nice and even coloration, that's good. When you start to see these dark areas, that's your tears drying up. And so in between your blinks, if your tears start to dry up like that, the quality of your vision will suffer. By the way, when you read, you don't blink as often. So when you don't blink as often, your eyes are more likely to dry out. That's why the most common times you'll notice dryness is when you're reading or driving or maybe watching TV. Things where you're concentrating on and not blinking as much, your eyes are more likely to dry out. And this is just kind of showing that in picture form. All right, so your tears, the tears that are in your eyes are not simple. So it sounds simple to say, I've got tears in my eyes, right? Our eyes make tears. Well, as it turns out, your tears are made up of well over 1,000 different proteins and other elements that make them what they are. So something that seems so simple and easy is not. They're very, very complex. And so, you hear about artificial tears. You can also, I guess, call them fake tears. Your natural tears aren't so easy to replicate. That's why there's not just one answer for what do we do. So I already mentioned not all artificial tears are the same. Last year in 2023, there were literally dozens of artificial tears pulled from the market by the FDA because of problems. And there were some foreign manufacturers that had some real problems. They actually produced contaminated bottles. The people then got eye infections. That then there were some people that lost vision because of eye infections from contaminated tears. There were people that had to have eyes removed. Now this is the one that's shocking, there were people that literally died because of contaminated artificial tears from foreign manufacturers. So when your eye doctor says use this tear, use that tear. Use a trusted brand. Now, how do you know what a trusted brand is when there's a bunch of different things on the shelves? You don't. You have to ask your eye doctor. I keep saying that, and it might sound self-serving, but if you have diabetes, you're going to ask your regular doctor, what medication do I take, right? You don't just go to the pharmacy and say, hey, give me some of that. You would never do that. And so artificial tears even are the same. Find out which one to take. Feel free to ask your eye doctor why that one. But find out which one to take. Make sure you're taking a trusted brand. Because if you go to the store, it looks like that. And how are you supposed to know which one to pick? You're not. You're not going to know which one to pick. You need to have a trusted source to know what can possibly work. So I already mentioned this idea of quantity and quality. Our eyes need enough tears of the right quality. If you're suffering either one of those two, then your eyes are likely to become dry. So it's both quantity and quality that are important. And by the way, depending on whether it's a quantity problem or quality problem, that may dictate which artificial tear to use, or it may dictate which prescription medication to use, whether it's an eye drop or a nose spray or something else, or even certain supplements. Does diet or nutrition matter? And the answer is an absolute yes, it does. There are things we can do through diet. There are supplements, just like there's supplements for macular degeneration. There are supplements you can take for dry eye, sometimes even just one pill a day to dramatically help dryness in your eyes. So again, ask your eye doctors, hey, is there a supplement available? If they say no, you can say, oh, yes, there is, because I heard in a seminar that there is. Maybe you need to look it up.
Tell us.
Well, there's a bunch. There's not just any one. Okay, so that's why it's a little bit tricky. So, you know, it's an unfair position for anyone to talk to a big group and someone says, tell us which one to take, because everyone's a little bit different, right? So if you say, name me 3, I'll tell you that a good quality fish oil for some people can be helpful. I'll tell you that you can go to the store and buy something called Blink Nutri-Tears. That's a once-a-day pill that helps dry eye. And then there's a number of different, what I would call doctor-directed brands. Meaning you go to your doctor and they either sell them in their office or will help you order something that's specific for dry eye. So there's a bunch of different options for different things that you can potentially take for dry eye. And just like anything else, a healthy diet, like a Mediterranean style diet, is the best thing you can do as far as what should I eat. There's different in-office procedures or things that can be done, whether it's using different lights. This is trying to look at the glands. There's little things that can be used to squeeze your eyelids to help get some of the secretions out that are supposed to come out. I only show you this because your doctor may offer you an in-office treatment that may sound kind of weird or like torture, that number 1, really don't hurt, and number 2, can sometimes be very helpful. Number 3, unfortunately, are not covered by insurance. It's unfortunate that sometimes there's things that work really well that insurance doesn't deem necessary or whatever and doesn't pay for. So, you know, don't be shocked if you have dry eyes and maybe you've already tried a few things. Your doctor says, I want to try X, Y, or Z that's in-office treatment, but it's an out-of-pocket expense. So just, again, that's one of the things I wanted to let you know. You may have heard, or sometimes doctors may talk about something called punctal plugs. Now this sounds really scary when patients hear about it, but it's one of the simplest things that your doctor can do in their office. So when you have a sink, you have a faucet that turns the water on, and you have a drain that lets the water out. That's what keeps the system working, right? You turn it on, you let it flow out. Our eyes produce tears, we have drains that let the tears out. What this is doing is it's putting a little plug, each eyelid, your upper and lower, has a drain. So what this is doing is putting a plug in the drain. And what that does, if your problem is not enough tears, this helps keeps the tears around longer. So this is a very easy in-office thing. This is covered by insurance, by the way, that if you have a problem with tear quantity, this can be very, very helpful, can be very beneficial. There's a number of prescription medications. 3 of these are eye drop, and then this 4th one is what someone asked about, a nasal spray. So usually when I bring that up to patients and say, you know, we're going to try a nose spray for your dry eye, they give me a look like, are you crazy? Like, I told you my eyes are dry, why do I need a nose spray? Well, it's because it helps your dry eye. And so I'll generally ask people, do you prefer an eye drop or a nose spray? Because some people already use nose sprays and that's easy for them and they hate eye drops. Great, there's an option for you. Some people don't use nose sprays and think that's a weird, freaky thing. Fantastic, there's eye drops for you. So there's different options that all can potentially work that your eye doctor can help guide you to. But the thing to realize is that if you have dry eyes and artificial tears don't work, okay, there's prescription medications. If you try a prescription medication and it doesn't work, okay, there's other options. So there's more than just 1 or 2 or 3 options for what can help you. Yes? So is there a correlation between your nose being dry and your eyes being dry? I'm going to say no, but not directly, just if one's dry then the other, but they're connected, okay? But the reason why the nose spray works has nothing to do with making your nose wet to then make your eyes wet. It works completely differently. So I totally understand why you would ask that, but they're connected. But some things may make them both dry, some things may make one dry and not the other. I'm kind of getting into it over there. So this is a slide just to point out that sometimes your eyes feel fine, but they're dry. That's the example I gave earlier of putting your hand in the stove that's on, right, the gas stove top. So oftentimes I tell people that their eyes are dry and they say, oh, they feel fine. Why should I do something about it? Well, it's because if it's not affecting your vision yet, it likely will if it gets worse and worse. If it's not affecting your eye comfort yet, it likely will if it gets worse and worse. So just like macular degeneration or diabetes-related eye problems, the earlier you catch something, dry eye, the easier it is to manage it and prevent complications later. So something that may seem very trivial now could become a bigger deal later if you don't address it. Another thing that I talk to patients about sometimes, it sounds super weird if you've never heard of it, is something called an amniotic membrane. This is something that's being used more and more commonly now. So most of you have probably heard of a placenta, like afterbirth, a placenta. So a placenta is made up of amniotic tissue. So this is essentially taking a placenta and making very, very thin little slices and either putting it on a contact lens or just creating little circles and putting it on the eye, which sounds cuckoo, but they oftentimes work incredibly well, almost like magic, in people that have dry eyes that aren't helped with other treatment modalities. So all the really healthy proteins and all the other regenerative stuff that's in that tissue goes into your eye and helps heal the front surface. So again, it's one of the things I always like to tell groups about because it sounds weird, but it can be tremendously, tremendously beneficial. That is covered by insurance, by the way. All right, what about eyelid changes? A lot of times it's changes to people's eyelids that actually create dryness. Some of you probably, when you've woken up before, you've noticed what you call sleep in your eye, or sometimes you just have generally crusty eyelids or eyelashes. That junk that's on your eyelids or eyelashes can get into your eyes and create dryness. It can change the tear quality or even quantity that you get because of the junk on your eyelids and eyelashes. There are drugs approved to help that. There are simple things depending on what's causing the flakiness, whether it's bacteria, whether it's what's called a little mite. Your doctor may have used a word called blepharitis. Blepharitis basically just means inflammation of the eyelids or eyelashes. Again, crusty stuff on your eyelids or eyelashes. Depending on what it is what you'll do about it. A lot of times doctors will say, well, just take a warm washcloth and hold it there for 30 seconds and then a little bit of rubbing and that'll fix it. Sometimes it does, but depending on what the issue is, that may not do it. So sometimes there's prescription treatments, sometimes there's over-the-counter treatments, it may be eye drops, they may be wipes that you buy in the store, they may be prescription things that you either wipe or spray on your eyes. Generally when you do those things is to get rid of whatever is living there and causing the problem, whether it be bacteria or mites. Now when I say that, most of you are thinking, I don't have bacteria on my eyelids, I don't have mites in my eyelashes. Guess what? You all do. Okay? Just naturally. There are more bacteria and other organisms in your body than there is of your body cells. Okay? So they live amongst us. It's just a matter of how much and is it causing a problem. And if there's enough to cause a problem, you may need to do something about it. So the one that's kind of the most fun to talk about is this little mite here that about 70% of people that are your age have these little mites in your eyelids, in your eyelashes. And there's a new drop that's been FDA approved and almost everybody gets rid of it. And so how do you know if you have this? Your eye doctor will tell you. If your eyes are red and your eyelids are kind of swollen, they can look at you with the microscope that they use to look at your eyes and tell this is what it is and take care of it. It sounds gross, but it's very common and it is very treatable. So don't be surprised if an eye doctor talks about that. What's a stye? A stye is basically a zit in your eyelid. It's kind of the same thing. What's the best treatment for a stye? Heat. So a hot washcloth, if you have a stye, hot washcloth or something hot that stays hot for like 5 minutes, 2 or 3 times a day, usually within a couple days it's gone. Sometimes styes don't go away in a couple days, and then you might need an oral antibiotic. So if you have a stye, the first treatment's always going to be heat. But if you do that for a couple days and it's not helping, then ask your doctor what's next. A stye is a problem inside the skin. It's not your eyeball, and that's why an eye drop is usually not going to be the best treatment forest eye. All right, so what I want you to realize about dry eyes, it's a real problem. It certainly can be problematic. It can usually be managed fairly well with the help of your eye doctor, whether it's through over-the-counter or prescription products. Not all drops, tears are the same, so follow the directions of your doctor. Really important to get a good recommendation and try to follow that. And again, just to tell you that dry eye is not at all related to dry macular degeneration. Two very different things. You might have both, but it's not one because of the other. Hang on to your questions. I'll take them at the end. So I think what we have next is So what we have next is, so I told you about digital monitoring. And so what we're going to do is we're going to hear from someone about digital monitoring of macular degeneration. This is for people with dry, and the whole idea of this device is to detect a change from dry to wet before you notice it in your vision. So it's testing you can do at home, and she'll go into great detail. Testing you can do at home with this device that for most people on Medicare costs nothing, that is way more effective than the grid that we talked a little bit about earlier. When this is done, I'll be happy to answer questions about this. So this is a video, but I'm happy to answer questions about this because I have dozens of people in my practice using it, or any other questions that you have, we'll answer after this.
Describe it, please.
What's that?
Describe the device, please.
Just-
How big is it? What is it like?
So I believe she will show you and talk through it, and if she doesn't, then I will at the end. All right, so I will leave it to Dr. Jacobs to tell you about what's called 4C Home.
Thank you so much for the introduction. The Nodal Vision Monitoring Center is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege to be able to do so. I would like to further discuss understanding the importance of detecting wet AMD early and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered, and it is prescribed by your eye care professional when appropriate, depending on your level of vision and your stage of AMD. It is a form of personalized medicine with the 4C Home device used at home in between your regular eye exams. The device is a metamorphopsia detector, which just means that it detects visual distortions in AMD. AMD is a leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic condition, meaning it does not resolve or go away, and it tends to progress or worsen over time. AMD progresses through three main stages: early, intermediate, and advanced stages. The advanced stage can be either advanced dry or wet AMD. Early and intermediate AMD are the slower changing, earlier form of the disease. However, once there's progression from the early to the intermediate stage, this puts one at risk for developing wet AMD. Not everyone with AMD progresses to wet AMD. However, those who do have a significant risk of vision loss, especially if not caught early. Wet AMD, which again is one of the advanced stages of the disease, can occur suddenly and without warning. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In the early and intermediate stages of dry AMD, changes occur in the cells of the macula and drusen, which are deposits built up in this area. These changes may induce blurry vision, such as difficulty seeing sharp details both up close and from a distance. Again, early and intermediate dry AMD are the slower forms of the disease, with changes you may not notice. Over time, the size and the number of the deposits in the macula can increase, which increases your risk of developing the more sight-threatening wet AMD. Intermediate dry AMD can suddenly change to wet AMD without advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula area. These blood vessels leak fluid and can sometimes bleed without any warning. You may not notice changes until significant vision loss has occurred. If you convert to wet AMD, significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, where straight lines begin to look wavy, dark spots or spots in the center of your vision, and generalized blurry vision can also be a symptom that patients may experience, as seen here on the screen. The good news is there are effective treatments for wet AMD. However, these treatments are most effective when administered early on, often before symptoms are noticed and vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but cannot restore vision that has already been lost. Once the wet disease starts, it tends to continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and often before symptoms are noticed. But how early is early detection? Once symptoms of visual impairment are noticed, like wavy lines or dark spots, vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision and your independence. So it is important to remember, wet AMD treatments are effective, but they are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps your doctor detect wet AMD often before visual changes have occurred. But how does it work? You take a simple daily test that checks for changes in your vision. The test takes a few minutes per eye per day. Data from each test is sent to your eye doctor as well as the Nodal Vision Monitoring Center, the provider of 4C Home. If a change in your test score is detected, the monitoring center alerts your doctor. Your doctor's office will determine the best course of action, which typically includes scheduling a follow-up visit. Testing with 4C Home is easy. Simply turn the device on and look into the viewfinder to begin testing. Take an easy test where a bump briefly appears and then disappears. Use the mouse provided to click where the bump appeared and then return to the center dot. Data from each test are sent to the Nodal Vision Monitoring Center for evaluation and also provided to your eye doctor. Regular at-home monitoring is like brushing your teeth. It's a good habit you do every day to help preserve vision. Our team will be sure to verify your insurance benefits and discuss those benefits with you prior to your acceptance of the device and getting started with the program. The Medicare-covered 4C Home is billed as a monthly service fee. There are low out-of-pocket costs for traditional Medicare patients, and depending on your coverage, you may pay nothing at all. If you do not have a secondary supplemental plan, you will pay around $15 per month after your Medicare fee-for-service deductible is met. 4C Home allows you to take a proactive approach to protect your vision. After the Nodal Vision Monitoring Center receives a referral from your doctor, we will answer any questions, verify coverage, and ship your device. Once you receive the device, the Nodal Vision Monitoring Center will walk you through setup and training. Once you begin testing, you and your doctor will continue to receive feedback from the Nodal Vision Monitoring Center. There are no obligations to enroll in the program, and you can cancel at any time. Managing your AMD with the 4C Home Monitoring Program can lead to significantly better outcomes. A major study showed that wet AMD is detected when the average vision is 20/83 in patients monitored using only standard of care, which means you wouldn't be able to see below the top 2 or 3 lines on a vision chart in your doctor's office. Numerous studies have shown that adding 4C Home to a doctor's standard care plan can help detect wet AMD while patients still have 20/40 or better vision. This is the vision required for unrestricted driving in many states. Hopefully I've given you some information on how you can take an active role in monitoring your eyes to give you the best visual outcome as you embark upon or continue your AMD journey. Thank you so much for your time today, and you may visit our website at 4chome.com or scan the QR code on the screen. Thank you.
All right, so any questions about that or anything else that we talked about? Yes?
Doctor, thank you for this very wonderful presentation. Appreciate it.
Sure.
I have 2 quick questions. You mentioned stem cells don't, cure or help with any of these, even dry eye, correct? I've recently heard about plasma-rich something, PR.
Yeah.
Could that help?
Yeah, so for dry eye, you can actually, there's a treatment where you go to a lab, you have blood drawn, and they filter certain things out of your blood and put that with sterile saline and use that as a tear. So there's a plasma type of teardrop for certain treatment for dry eyes.
Okay. And the other question, I don't know the medical term, but I've heard it referred to as an ocular migraine, where you see flashing lights. Is that a precursor to macular degeneration?
Yeah, so ophthalmic or ocular migraine, so a classic migraine headache, you get these weird visual symptoms, and then that stops, and then you get a terrible headache. An ophthalmic migraine or ocular migraine is where you only have the weird vision symptoms, and is totally unrelated to macular degeneration. It's actually not even an eye condition. So it's something that's purely neurologic that we recognize because of what we see through our eyes, because our eyes are essentially part of the nervous system. So unrelated to macular degeneration. Good question though. Yes?
I have a cousin that lives in Italy, and he told me that he had macular degeneration and he was able to have surgery. What are they doing in Europe that we're not doing here?
So historically there was surgery tried for wet macular degeneration here and it was proven not to work. So I'm not aware of what they would be doing in Europe. There's a couple different surgeries that have been tried here for different stages or different complications of macular degeneration that in the average person with macular degeneration don't really work. So I don't know what they would be doing in Europe that would be different and beneficial. Yes, ma'am.
Ocular rosacea.
Ocular rosacea. So if you think about when you're younger and you had acne, you may also have had or have what's called ocular rosacea. And it is a very common reason for people to have dry eyes. So just like if you have rosacea on your skin, it affects your skin, you get pimples, it clogs glands. Ocular rosacea can cause basically plugging or irregularities in the glands that produce different parts of our tears. So it can cause dry eye. The treatment for that is oftentimes different than, I guess, your more garden variety dry eye. So that's why it's important to differentiate why are my eyes dry. Yes, Fred? Yes, Dustin? So one thing that I think they're doing more of in Europe than they are here, that Dusty reminded me of, is for people with macular degeneration that haven't had cataract surgery, that need cataract surgery, it's possible to have cataract surgery and have a telescope implanted to basically act like a magnifier in that eye. So that's something that you actually can get done in this country. It's just not very commonly done. There's not a whole lot of places that actually do it, but that's one surgery for macular degeneration. It doesn't affect the macular degeneration. It's basically a low vision type of treatment to improve your functionality. Yes?
For all of these different options that you've described for dry eyes, are those available through a regular
Yes.
ophthalmologist, or do you have to go to a specialist?
No, so any optometrist, ophthalmologist can prescribe any of these dry eye treatments. Good question, yes?
Some of the eye drops have preservatives and some
Uh-huh.
what's the difference?
So some eye drops have preservatives, some do not. Preservatives make it so you can have something in a bottle and it'll last longer. For some people, preservatives can cause irritation and dry eye. So what I generally tell people is if you're going to use eye drops 2 or 3 times a day, even if it has preservatives, you're probably okay. Although preservative-free would be better. If you're using eye drops 4 or more times a day, you probably should be using preservative-free. Otherwise, all the preservatives can cause a problem. It's never worse or harmful to use preservative-free. It's just sometimes they're more expensive.
And then what about floaters?
What about floaters? So good question. Floaters are very, very common. It's a pretty natural thing to happen that happens to most people. Floaters generally are when the gel inside your eye changes. What I tell people, floaters and cataracts are both things that come with birthdays. That the more birthdays you have, the more likely you are to ultimately get those 2 things. So floaters are basically it's changes to the gel inside the eye that when light comes into your eye casts a shadow. So you see these little things floating around. But what you do about it is either nothing, which is what almost everyone does about it, because for most people you notice them when they first start for a month or 2, and then they mostly go away. There's a laser procedure you can have for them, but not many people have the laser done because it has to be a very specific type and location of floater. You can actually have surgery for floaters, which is a fairly dramatic step that even the people that do that surgery don't do it very often because it's usually the risks outweigh the benefits. And there's actually a vitamin supplement that a company has that purports to decrease the symptoms from floaters. The vitamin is called, I'll give you the name of this one because there's only one. It's called Vitreous Health. So it's called Vitreous Health, and actually if you go on our website, one of the sponsors for macular degeneration, the company is called MacuHealth. And so it's a MacuHealth product called Vitreous Health. I believe Donna has some of their cards that will be at the table when you go to check out. I think she'll have,
I'll give them to you because
she has a few up front. So that's for the company. They have a number of different vitamins, but Vitreous Health in their study showed some benefit to some people with floaters. Yes?
So how big are floaters? Because I see things that sometimes look like I have an afternoon, but it's like the line drawing through it, so you can't really see any map.
Yeah.
But it's just a shape in it, and I move my eye.
It moves, yeah. So floaters can be tiny, they can be big. Some people see them all the time, some people just rarely or occasionally. So they're very variable. Just like you, if it's truly floaters in the gel, just like you see them looking out, I as an eye doctor should be able to see them looking in. I should be able to see the same thing that you're seeing. I may not describe it the same way, but at least its presence, I should be able to see that if it's there, if that's what's causing the issue.
Okay, and if you don't mind on these, I go from bright light to dark.
Yeah, so it's normally in certain lighting conditions. So usually it's if you're in a brightly lit room with a very uniform background, that's usually when people will notice it. But everyone's gonna have a kind of a different situation when they notice it the most. There was a hand in back, I thought, over here. No, then we'll go to the hand in back over here.
I've had 2 vitreous detachments, one in each eye, and do those in any way contribute to macular degeneration?
So vitreous detachment is basically what that ultimately causes floaters. So vitreous is the gel in your eye, and when we're younger, it's attached to the back, to the retina. And then as we have more birthdays, it changes and often becomes detached or pulled away. Not a retinal detachment. A retinal detachment's a big deal. Vitreous detachment, no big deal. Just can be annoying because of the floaters, but it has nothing to do with macular degeneration. It doesn't cause it. One doesn't cause or protect from the other. Yes?
Sir, I don't know if anybody asked the question, because I don't hear well, but why is it that we lose our reading capability as we age?
Yeah, so the reason that usually starts when you get to be about 40, they start to not see as well up close. There's a lens in our eye that when we're younger is very elastic and is able to change its shape. And as we age, that stops happening. And so it's unable to change its shape and focus. And so that's why somewhere between 40 and 50, most of us start to need to wear bifocals.
Thank you.
Yes. Yep, go over there.
When you talk about the center of vision, losing the center of vision, in mine, it seems that it's not actually the center, it's over like to the right. And is that?
Yeah, so the way to think about the macula is I describe it as the bullseye on a dartboard, but the reality is on a dartboard, you generally have the bullseye that's red, and then you have a small ring around that. So the reality is in your eye, your macula is actually not just the red bullseye, it's also that small ring around it. So macular degeneration can happen anywhere in that general area, so it may not be smack dab in the very middle, it could be just a little off to the side. Yes, ma'am.
When I was about 45 or 50, at nighttime, when I was driving, I would see flashes of light. So I went to the eye doctor, and he said that as we get older, that it gets stiffer. And so when you move your eye, it pulls it away from the, so he didn't recommend anything. He thought it would probably, I'd adapt to it. But I had a girlfriend who was involved with vitamins, and she recommended these drops that they put out for eyes. They're MSM drops. And so I started taking those. And this has gone away. And not only that, but now I have glaucoma. And so the doctor has me taking 1 drop of glaucoma medicine in each eye each day. But I also take 1 drop of the MSM.
What's MSM stand for?
I forget, it's something. But it's a vitamin that you can take internally. It's a common vitamin. And I showed the doctor that I was taking them, and he said, well, that's all right, but he didn't necessarily prescribe.
Yeah, so what I would tell you most of the time with, I'll just say different vitamins, is that they may or may not help. And then the most important thing about anything like that is that make sure that there's little potential for harm. Right, so something may be worth trying if there's no harm, but pretty much any doctor's standard should be, is there some sort of clinical trial or something that tells me that it works? And as a doctor, that's what I make recommendations based on, which is going to be different than, if someone is a vitamin advocate that is not an actual medical professional, how or why they recommend things may be a little different. But if you try something and it's working and it's not causing harm, then there's not much downside. But I would just be careful with things like that there's not necessarily proof that it works.
But, one of the things that does help with is dry eye.
Yeah, well, virtually anything you put in your eye, as long as it doesn't have some sort of toxic preservative, is likely to help the way your eyes feel for dry eye.
It doesn't hurt in my eyes. In fact, what it does is it makes the eye more flexible. So the things in there are more flexible. It doesn't stiffen up.
News to me. But okay, one or two more, and then we need to go because we have to go to Phoenix. Yeah.
How do you know that the eye drop is preservative free?
You'll know if an eye drop is preservative free because it'll say it on the box or the bottle that it comes in. Yeah, it'll always say that.
Always say what? I'm sorry.
If it's preservative free, it'll say so on the bottle or on the box that it comes in. Yeah. Yes, last one. Make it a good question.
Yeah.
It's the last one.
What does the placebo effect?
Placebo effect, yeah. So that's why I mentioned that anything to use, it should be something that's proven in a clinical trial because it takes that out of it. So, you can try anything, and if it works, it could be because you told yourself it was going to work and therefore it worked. But if there's a trial with 1,000 people and half the people get nothing and half the people get something and the people that got something did better, we know that it's real. So that's why I bring up the idea of something that's science-based or from a clinical trial to know. Something that hasn't been in a clinical trial may still work. And it may work for you. And at some point you may say, I don't care how or why it works for me. If it works for me, that's all that matters. I can't make recommendations or prescriptions based on, I assume maybe it could. It has to, for me as a physician, it has to be, this has been proven, therefore we'll try it. All right, so I'll stick around for a couple minutes to answer a couple questions, but Donna's collecting the survey, so if you could please fill out the survey, those are really helpful for us. I want to thank Tucson Society of Blind for coming and being here in full force wearing their t-shirts. I've probably done like 20 of these so far, and this is the first time that a group showed up in t-shirts, so kudos to you for that. Don't forget to go to the Macular Degeneration Association website. It's macularhope.org. Great information. And last but not least, just to thank Donna for organizing and putting this together. And Dusty for being the AD guy, because if she wasn't here, the only thing you would have heard would have been church next door. So thank you, Dusty.